All right, so switching gears just a little bit, right ventricular MIs. So we've been talking about left ventricular MIs the whole time, inferior wall, anterior wall, septal, right, lateral wall, low lateral, high lateral. But now now we just get the lonely RV, right? There's a little RV right there. So we've been talking about the LV the whole time, now the RV. And it's actually very important because it's very deadly when you have an RV MI. So we want to make sure that we are recognizing it. And so anytime you have a MI findings, you have STEMIs or ST depression and 2,3 AVF, you want to consider an RV-MI as worst case scenario, right? Because if you look here, here's our right coronary, right? And it comes off. Yeah, it goes down to the posterior descending artery eventually, 80% of the time. But then look at the first stop right there. First stop is the RV, right? Second stop is the inferior wall, right, of the inferior wall of the left ventricle. All right, but the first stop is the RV. So if you have an occlusion, if you have a blockage all the way up top there, proximally, then you could have RV dysfunction, right? You could have an RV MI in your hands. I mean, if it's just below that branch, then yeah, it could be an inferior wall MI. If it's, and of course, posterior walls will be affected as well, depending if the other 20%, right? The other 20% is of the posterior wall is fed by what artery? Not the ramus. The ramus sounds like a great thing, but it only happens like 10% of the time. It's the left circumflex, right? Left circumflex feeds the posterior wall of the left ventricle, and so does the RCA. So we're looking at the branches here. So we come off the RCA, first branch RV, next branch of inferior wall of the left ventricle, right? And then we go with the posterior wall, posterior descending artery, right? That's 80% of the time. Okay, so when you have inferior wall MI, it's like, well, shoot, was the blockage maybe higher up, and it could be an RV failure as well. Okay, and how do you find this? Is there an EKG finding? No, there isn't one standardly. So we have to throw instead of going V1 to V6 this way, we're going to go V1 to V6 the other way, going right? And they did some research, and we don't have to do the whole thing because it'd be confusing. Because you're like, oh, was that V1 or V2, right? You just have to do V4. All right, so you just throw a lead right on the chest on this side, right? So V4R, right? Just anterior axillary line right there. That's our V4R. You slap a lead right there, and that should detect a right ventricular MI, majority of the time. Okay, so this is how you detect it. So you can see here they did a 12 lead, and they just changed it to V4R, right? They just changed instead of V5, V6, or V4, V5, V6 on the left side, it says V4, V5, V6 on the right side instead. Okay, and up top here, see that V1R is this lead right there. It's the left sternal border. So it's just kind of what we are used to, but it's just all flipped, right? So V1 has the left sternal border, V2 right sternal border, and so on. But the one we're looking at is V4R. See, or over here, sorry, V4R. But look at that ST elevation. That's some nice, beautiful ST elevation right there, and that is at risk for right ventricular failure when you have a right ventricular MI and it's not reperfused. And which vessel would we be reperfusing if this happened? RCA, right? Remember, RCA is what comes off the aorta right there. And the first stop, that means we probably had a blockage right there instead of right here. So we had blockage at A, not B, right? If you have blockage at B, yeah, you would have inferior wall MI changes, you have ST elevation, you could even have a PDA changes, but we're seeing that it's a little more proximal, right? So 60% of RC occlusions are below it, but 40%. I mean, that's like flipping a coin almost. About 40% of your MIs or your RCA MIs are involved the right ventricle. Okay, so V4R, not AVR, right? AVR, remember I told you was useless, except for when it's not, which we'll discuss in the next couple slides, right, when it's not useless. But it is, we're looking usually at everything else except for AVR. And here at V4R, you're not going to find your standard 12 lead. You have to just move the lead over, and you can grab a V4R or a right-sided EKG. Okay, and when you print it out, you'll get to write the word R on next to it. Okay, or write the letter R. Okay, so that's the idea behind a right ventricular MI. And then why is it bad? Why is it deadly? So this is the downward spiral, as you can see. It's a huge spiral of death that happens when you have RV failure. All right, so again, the coronaries, right, they are fed during diastole, okay? So our coronary arteries are blocked by the aortic valve, and it's not until after they close, right, during systole, that we are, during diastole, then that's when we are able to perfuse our coronaries. Our coronaries are then able to be perfused when we have diastole, right? So we can understand what the left coronary arteries or left ventricle gets perfused at, how much blood flow it's getting, and how much the right ventricle is getting. And it kind of makes sense if it's their diastolic blood pressure minus the pressure in the left ventricle. If I'm trying to squeeze all of this blood, right, I'm trying to perfuse my coronaries, it's going to be dependent on how much stretch there is, how much pressure there's in that left ventricle, right? As I remember we mentioned, like subendocardial ischemia, right? When we're trying to feed our myocardium, right? It feeds from the top or outside in, right? So if there's a lot of stretch on the inside, it's going to be difficult to feed that myocardium, right? And what's coming in the other side, right over here, that's my diastolic blood pressure. So diastolic blood pressure minus the left ventricular end diastolic pressure, which you can't really get until you're in cath lab, but you can kind of estimate it with a swan. All right, so that's your perfusion of my coronaries, and it's actually pretty low. It's like around 40, right? So it's a really, really low pressure that, a MAP. You can understand it's the perfusion of my myocardium, 40, right? Perfusion of my kidneys, they like 60, right? We choose 65 just so they get happy, right? And then, a liver can be all the way down to 25. So there's a lot of organs that have different MAPs. The brain, it likes around 60 also, right? So that's what when we consider, like when we talk about brain perfusion, we think about the intracranial pressure is pushing back the other way, right? And the MAP going towards the brain and the ICP coming down, what's the perfusion end up being? So it's CPP is your MAP minus your ICP. Same kind of thing. So perfusion of the myocardium is the diastolic blood pressure minus the pressure on the other side, right? The pressure coming this way versus the pressure that we're delivering. All right, so that is our left coronary perfusion. What about the right side? So the right side is perfused during diastole, but what's the pressure on the other side? The pressure on the other side is this right ventricular pressure, and we know what that is. That's your CVP, right? So your CVP is your estimate of your right ventricular pressure. So diastolic blood pressure minus CVP is how much perfusion my kidneys get, or sorry, my right ventricle gets when it's getting via the right coronary artery. And then it used to be thought that, oh, if someone's RV failure, give fluids, they're preload dependent. That's the worst thing you could do is raise the CVP and someone has RV failure, because it's going to, if you raise this CVP number, right, that's going to reduce the perfusion to the heart. So we want to be very careful about that. We want to unload the heart as much as possible. So CVP should not be high, and you should have on the other side, where does the right ventricle go? It pumps blood where? Into the lungs, right? So you want the lung pressures to be nice and low. You don't want those to be super vasoconstricted. So when someone has like chronic hypoxia, they can develop RV failure and they can develop an RVMI. Or in the situation right here, if they're hypoxic, we don't want them to be hypoxic. And if they have a huge PE, that can start causing a lot of problems in of itself, in addition if they have RVMI or not. So we want to make sure that the pulmonaries are nice and vasodilated. So we have medications that can do that for us to do pulmonary vasodilation, but also we want to unload the RV as much as possible. Okay, so more fluid will raise the CVP and lower the right coronary perfusion. So this is a death spiral, right? So if we increase RV afterload, what is afterload? That is what? That's the pressure. That's what? That ventricles have to overcome, right? So when this aortic valve, for instance, when it tries to open up, it has to overcome the diastolic blood pressure on the other side of that valve. So that's the diastolic blood pressure is your afterload for the LV, right? On the other side, we can measure PA pressures, right? We can measure the afterload of the RV. How much pressure is this RV have to eject against into the pulmonary circulation? We want these pulmonaries to be nice and dilated, not constricted. When they're constricted, that's going to make it much more difficult for that RV to unload. And they might be constricted or might be impaired because there's a pulmonary embolism in the way, right? What else might impair it? What else might increase the workload of the right ventricle?
Like a pneumonia?
Yeah, give it pneumonia, or we could just straight up just have them on a ventilator. Right? That's positive pressure ventilation inside the chest. And that's going to put a lot more strain on the heart, on especially the right heart. Left heart loves positive pressure in the chest. That positive pressure in the chest squeezes blood distally and then now it opens up the thorax for the next cardiac cycle. It's beautiful, right? But the RV, it's the one that doesn't luck out in that situation. And what happens if your RV fails? Like, oh, big deal, I still got a left ventricle. Well, your RV delivers blood to your lungs, and that lung goes to the left ventricle, right? So you need both ventricles to be working and operational. right? And then oftentimes also when you have RV strain and RV failure, it's actually pushing the left ventricle and making it so that it can't fill adequately. So your blood pressure gets low on two fronts, right? Your blood pressure is low because the RV is super dilated and it's dying, and it's pushing the LV, and the LV can't fill up with blood. And also the RV is not able to pump blood forward. Its cardiac output is poor, and therefore the LV's cardiac output is poor. And the LV cardiac output is poor, its diastolic blood pressure is low. If its diastolic blood pressure is low, then that means you have low flow to both coronaries, right? So it's a very, very dramatic downward spiral, right? Increased RV afterload is decreased RV cardiac output. RV dilation puts a lot of extra pressure on the LV. LV can't fill, therefore I have a decreased MAP, or decreased blood pressure, right? Decreased diastolic blood pressure. And that's going to lead to further ischemia, right? Ischemia happens when your MAP starts dropping and dropping, or the perfusion of an organ keeps dropping and dropping. So we're going to get more ischemia. More ischemia means more MI. More MI means less cardiac output. So it's a whole downward spiral that we want to try to avoid, ideally, right? And how can we avoid that? We can hopefully unload the lungs as much as possible, and improve the blood pressure. And when we talk about cardiogenic shock is very, very difficult to fix based on compared to other shocks. Other shocks, you just squeeze the induce a vasoconstriction, right? But that can put extra strain on the heart sometimes. So the idea here is that we avoid this death spiral as much as possible. These patients, when you intubate them, we want to try to avoid intubation if we can. We're going to try to unload them and diurese them, reduce the CVP, do some pulmonary vasodilation if we can, to try to avoid RV failure, right? Use your RV and LV don't really communicate with each other, right? The LV just expects the RV to deliver blood to the lungs and then return my blood to me, right? But all of a sudden, when I start getting this pushing of the RV into the LV, now we have this interdependence. We have this push, and now the LV is now being more and more affected. Okay, so that's the idea behind RV failure. We want to make sure that we are, perfusing the RV and the LV by having adequate diastolic blood pressures and making sure that the ventricles don't fill up with too much blood on either side. Obviously, really, really bad CHF, you're going to have lack of perfusion to the coronaries, right? As they get more and more dilated, I should say, with reduced ejection fraction CHF. And then when someone is like in cardiogenic shock because of an MI, that's why it's a downward spiral. We want to improve inotropy as much as possible in those patients to help squeeze and reduce the pressure inside the ventricle at the endodiastole. You don't want there to be a lot of fluid in there, otherwise it's pushing back on my coronary perfusion, right? So I want to make sure that they're getting perfused as best as possible. So this is why it's important to detect RVMIs, because we want to make sure they are optimized as much as possible. Like for LV failure, we don't want to overload them, right? You're not going to give fluids to someone with LV failure. You're not going to give fluids also to someone with RV failure. All right, so that's the importance of why we want to detect an RVMI. All right, so again, I told you AVR is the stepchild until it's important, right? You realize that it's actually Harry Potter the whole time, right? So it's it's the one that you want that can give you good information on certain situations. So it's mostly useless until it's not. So when is it not? Is when it has ST elevation or ST depression. So usually AVR is not affected, but if it is affected, it might be something. If it's depressed, right? AVR is depressed, it's pericarditis. We'll talk about in the next slide. But if it has ST elevation, you're gonna pump the brakes and say, whoa, I got AVR ST elevation going on. Why is that, right? If I have AVR ST elevation, I look at my other leads, and if I have ST depression, like very, very diffuse and many, many leads here, that is something that could be actually a left main disease, right? It can mean my left main is actually occluded. It's not 100%, because at 100%, you would not see the patient in front of you. They would be dead, right? If the left main was 100% occluded. But they definitely have they probably have some collaterals that are letting them getting some flow into the left ventricle. So this is a sign of this really profound ischemia. So if you imagine that I have all this, there's no flow at all in my ventricle, I'm going to be able to see this ST elevation on this side, right, on an AVR. So that's the only time that's why it's useful in this situation, right? So if you imagine like reciprocal leads, like we talked about with posterior wall MIs, V1 showed ST depression, right? ST depression, and then we slapped a lead on the back of the chest, like V9, then we were able to see ST elevation, right? So that's just a reciprocal change, right? So you can see reciprocal changes here. If I have no flow on this side, I'm going to see the reciprocal change on the other side, right? So I'm seeing ST depression over here, reciprocal to the ST elevation of my AVR. So that's why it's important until it's, or it's not important until it's not, all right? Or it's not a better way to say that. It's not important until it actually shows some ST changes, okay? So that's the idea, right? Usually patients with left main STEMIs, they present dead. But if they have some collateral circulation, they're like really limping along, like 99%, 95% stenosis, they may make it there. They're obviously probably being extremists, right? They're probably gonna be really sick, really short of breath, all the SNS symptoms are firing off, really diaphoretic, and then you do a 12 lead, and you're like, oh, you're fine. I'll call cardiology in the morning. No, when you see some AVR ST elevation, that is significant. And they say, yeah, the AVR ST elevation should be bigger than the V1, all right? Because V1 is kind of offset just a little bit. All right, so the degree of AVR ST elevation actually equivalent to the amount of mortality, right? So it's greater than 1.5, that's almost like 20 to 75% mortality, which is ridiculous, right? When you put a central line in, there's a 1% chance of a pneumothorax, and a pneumothorax itself has like a 20%, 10% risk of mortality if it develops tension and such. So it's a very, very big mortality, but you're 20 to 75% mortality. Okay, so what else? So there are mimics. So when it's a younger patient or they have really profound tachycardia for a long period of time, that could put a lot of stress on the heart. Someone just got shocked, someone just had a CPR, that could also lead to this. All right, and yes, an MI can lead to CPR too. So that's what requires an expert investigation, right? Is what ACLS tells us. Just get someone involved so we can see, is there something more at work here? Okay, and they also recommend doing 12 leads about, I think they say 8 minutes, I think it is, after an arrest, because if you do it immediate arrest, you're going to see definitely ST changes. But if you wait 8 minutes, that's more confirmatory. Okay, yes.
So with that bottom left one right there, since there's only elevation in AVR, the criteria becomes inclusionary because of all the other depression.
Yeah, so there's not so much here. Yes, there's a little ST depression there, but we got ST elevation right here in AVR, right?
There's normally 2 or more leads of ST elevation.
Correct. Yeah. When you're talking about contiguous leads, yeah, AVR is the only. If you remember our axis system, AVR is the only one up here in no man's land, right? It's all the way up here by itself. Everything else is all down here, right? 1 AVL is up top left, right? We got 2, 3 AVF on the bottom. Those are all doing their own thing, looking at the left ventricle like they should. AVR is all the way up in the top, just in case, right? It's all the way where they call it no man's land, because you shouldn't have an axis deviation going towards this, right? Your axis should be going down and to the left. That's where most of your electricity is going. But if they have a large MI like this, you're going to see the axis deviation go up towards AVR. Okay. All right, so that's the idea behind AVR ST elevation. Okay, so this ST elevation AVR right here. Look at this profound depression. If I had that profound depression of V1 through V3, I'd be thinking of what kind of STEMI? Not right side, but yeah, something that the RCA feeds. Posterior wall MI, right? If I see like V1 through V3 ST depression, I'm thinking of posterior wall MI, right? But I see like it's profound ST depression over here, right? A little bit ST depression over here, right? A little bit there, but definitely some AVR ST elevation. That is considered a huge MI, right? That we want to escalate. Okay, this guy over here, there's definitely some ST depression there. ST depression, even in 2 and AVF. It doesn't make sense. Why would I have ST depression in V6 and lead 2? There's no coronaries that feed both of those, right? Yeah, they could have a right-sided and left-sided, but usually when someone comes to the hospital, it's because one vessel occluded, not all of them, right? So one vessel is down at this time. So the vessel that's down in this place, in this situation, is a left main, okay, that they need to, hurriedly go to the cath lab, right? All right, so pericarditis, the other important reason for AVR. So there's going to be diffuse ST elevation everywhere except for AVR. AVR is going to have ST depression. Okay, so you can see here we got AVR, ST depression, and obviously these are examples of pericarditis. So we're going to see ST elevation in many, many leads. So again, lead 2 and V6, 2, 3 AVF, look at my inferior wall, V5, V6, look at my lateral wall. Why is my right coronary and my left coronary down, or left circumflex down at the same time, or left or diagonals, right? and obtuse marginals. What's going on? Why? How is that even possible? So the way it's possible is because I was taking another look and say, well, shoot, what's going on with AVR, right? If AVR is ST depression, that's pericarditis, and usually the patient in front of you has chest pain that gets better when they lean forward, right? Or worse, when they lay flat. So that's someone that and they're probably febrile, they have a white count, they are a more infectious process, right? So that's how you would tell the difference between, someone that's having MI in front of you versus someone that's having an actual MI, okay? So that's besides that, pericarditis versus an MI. Pericarditis has the friction rub, yes, has the chest pain, but it's worse when they lean back, right? It gets better when they lean forward. And yeah, in worst case scenario, they could get fluid around the pericardium that fills up and fills up and fills up. And so yeah, that patient could have tamponade symptoms. That's why they presented to the hospital. At home, they had a fever, they're sweaty, they're getting through it, they're drinking Gatorade, Powerade, all the aids, and then they are coming to the hospital because they are feeling weak and fatigued, and they get some chest pain, shortness of breath, hypotension, confusion, because they get all this swelling and fluid around the heart, right? And like right now, if I injected your heart with 5 cc's sterilely with a fluid, you're going to go into cardiac tamponade, you're going to probably arrest, right? So just 5 cc's will do it. Whereas someone with pericarditis that develops this over a week or 2 months or 3 weeks, whatever it may be, they can develop up to like 1 liter of fluid. So it's ridiculous comparing acute versus chronic pericarditis, or I should say acute versus chronic tamponade, right? Your body can adapt greatly. Right? So pericarditis, don't be surprised. You can look at the echo, or if you appreciate an echo of these guys, there's a huge amount of fluid around that heart, right? And they feel a lot better when you take it off, right? They've been compensating for a while. Obviously, like a traumatic arrest or something, when they get a coronary that gets ruptured, or an LV that gets ruptured, that coronary, that blood is going to fill up real quick, and that 5 cc's will do it, right? Yes?
So with the arrows that you have pointing up, what leads are those?
So that's V6 over here. We got ST elevation, right? We got some ST elevation and lead 2. We got some lead AVF. Lead 2, 3, and AVF are elevated. So it doesn't make sense. It doesn't have the regular pattern we expect, right? With 2, 3 AVF, ST elevation, you'd expect maybe some reciprocal changes in 1 AVL, but you wouldn't expect there to be the lateral wall which is fed by your left side, right, and your 2, 3 AVF fed by your right side, right? They wouldn't have. Why would left and right be down at the same time, right? Just doesn't happen, right? Even if you had like the worst case scenario, left main disease, that's the left main. The 2, 3 AVF would be really pretty much unaffected, okay? So that's the idea with pericarditis. You're going to have ST elevation in most leads, and it doesn't really make sense, right? And then the other piece to kind of confirm it is AVR is ST what? Depressed. And then also kind of the symptoms, right? They don't describe typical ACS symptoms. What's a typical ACS symptom when you talk about chest pain?
Maybe like extremity pain.
So extremity pain, yeah. So it's radiating, right? So it's radiating to the left arm or both arms or jaw, and it's also what other characteristic? So it's pressure, and it's not positional, right? That's how you know that it's ACS MI kind of pain. It's pressure that radiates. It's substernal. It radiates to upward to the jaw or to the arms, and it's non-positional, right? So if it gets better with moving, that's not an MI, right? That is something else, and it could be pericarditis, right? And 12 lead can help us out. Obviously, we're going to get an echo to see if there's effusions, and you can see pericarditis on the echo as well. Okay, so here's a summary slide of what we've been talking about as far as putting it all together. And again, remember, it's 3 levels. The first level is knowing your ST elevation in the first place, and where on the EKG what is inferior, what is lateral, what is anterior, what is septal. And the next layer is knowing what vessel feeds it. So it's kind of color coded for you. So in red are the vessels, in yellow is the location, right? And also in blue, I just highlighted when it's like reciprocal changes, right? So remember we said ST elevation and AVR, that's what we just talked about. We have, this is the only time where AVR is useful, is when you have ST elevation in it. When you have AVR, ST elevation, and you see ST depression elsewhere, that's kind of your reciprocal change, right? And then AVR, if you have ST depression, you're thinking pericarditis, not really thinking a MI of some sorts, okay? So remember 2, 3 AVF, these are looking at what? The inferior wall of which ventricle? left ventricle fed by the RCA, right? So inferior leads are here in 2-3 AVF, right there in the corner. It just checks a box for me. That's all there in one spot. Everything else is not in one spot. So 2-3 AVF is right there in the corner. All right, over here is another way to look at it. And then we have these are your limb leads, right? Your limb leads are 2-3 AVF, but also which other two leads are limb leads? Remember your EKG, your 12 leads split in half. One half is limb, the other half is they call them chest leads also, but also precordial leads, right? So precordial leads, so just to finish out the picture of our limb leads, this is organized by limb leads here. You got 1 AVL, and then you have 2-3 AVF, and our stepchild's AVR, right? Those are our limb leads. And then our precordial leads here, right? Our precordial leads are looking at our V1 through V6, but V1 and V2 are fed by the LAD right here, right? So V1, V2 are fed by the LAD, and that V1, V2 is feeding what? What part of the heart? Or is looking at what part of the heart, which is fed by the LAD? The septum, right? And then the LAD also is it's a widowmaker. It's going to also feed what other part of the heart?
Left ventricle.
Left ventricle, right? Which part of the left ventricle? Because we have the inferior wall is fed by the left ventricle, posterior wall, lateral wall, which wall? Anterior wall, right? So V3 and V4 and V4 up here, those are your anterior leads, right? So your anterior wall being fed by your LAD, and yes, the LAD feeds the septum as well. So sometimes you get anteroseptal MIs, or sometimes it's just the septum, just a little portion of the LAD, or you get the whole LAD, a little more proximal occlusion on the LAD can cause some damage, some lack of flow to the distal anterior wall, right? And to the septum, so anteroseptal, right? And then we've got septal MIs, anterior MIs, and those are fed by the LAD. And then we have the lateral walls, right? The lateral wall can be fed by the left circumflex up top, right? So the left circumflex is at the top there, and the other ones are your obtuse marginals, right? So those are your OMs and distal left circumflex. Those are what feed the high lateral versus low lateral walls, right? So a lateral wall MI could be due to one of those two areas being occluded, right? So it's either V5, V6, or the other option is no. So lateral wall is assessed on the 12 lead by looking at V5, V6, and 1 AVL. So you see V5, V6 here are looking at the lateral wall, right? And then 1 AVL over here, right? 1 and AVL are looking at the high lateral wall. They're looking a little higher up, okay? So V5, V6, this picture is kind of hard to assess, but it is a little bit lower, right? So those are looking at your lateral wall. So we can tell if it's an obtuse marginal that's occluded, or we can tell if it's the left circumflex that's occluded. If both of them have ST elevation, that probably means it was more proximal on the circumflex that got blocked before it was able to branch off to the obtuse marginal, right? Because we have our left main right here coming off our aorta, right? And then we take a going south, going to our LAD with our LAD, or we can keep going, keep going east, right? So we can then hit, that's our left circumflex, right? And then off the left circumflex, we have little obtuse marginals, right? But if the blockage is all the way over here, obviously we're gonna get ST elevation in both lateral walls, in the low lateral and the high lateral, all right? And then same thing when I talk about LAD, when I have a blockage LAD up top, that's right before I have little septal perforators that come off, right? And also there's some diagonals that also come off the LAD. So you can have them, you'll see changes in like the anterior wall only, just like V3, V4. If you see changes in V1, V2, V3, V4, that's anteroseptal. That means I had a blockage much more proximal, okay? All right, so this is our summary slide, and now we're gonna do some EKG practice.